given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any persons or entity by name or in such a way as to make him or her or it identifiable. Members are reminded of the provisions within Standing Order 186 that the committee shall also refrain from inquiring into the merits of a policy or policies of the government or a minister of the government, or the merits of the objectives of such policies. While we expect witnesses to answer questions asked by the committee clearly and with candour, witnesses can and should expect to be treated fairly and with respect and consideration at all times in accordance with the witness protocol. So, Mr Breslin, could we have your opening remarks, please?
Thank you, Chair. I would like to thank the Chair and members of the committee for the opportunity to discuss the arrangement made with private hospitals in response to the Covid-19 pandemic. I note that the committee in its invitation indicated it was particularly interested in the use of the capacity of the private hospitals and the impact on continuity of care and treatment of private patients. Before I address these specific issues, I'd like to remind members of the context within which the arrangement was rapidly put in place. The arrangement was concluded at the end of March at a time when epidemiological projections for the disease indicated we faced a surge of cases which had the potential to overwhelm our health system. The European Centre for Disease Control was clear that all European health systems face such a risk at this time as we watch regions and countries struggling to manage. It was recognised that the HSE urgently needed additional acute hospital capacity to deal with the anticipated crisis and to protect other urgent time-critical emergency services. On the 16th of March, the Government's action plan in response to Covid-19 identified the need to increase acute hospital capacity, and so on the 30th of March, following intense negotiation by the HSE and the Department, we reached agreement with the private hospitals. On that day, there were 111 patients with Covid-19 in ICU in our public hospitals. This had more than doubled over the previous week. The agreement, which has been laid before the Houses of the Oireachtas, gave the HSE immediate access to an additional 2,500 beds, over 100 of which were critical care beds, on a cost-only open book basis. Thankfully, the public health measures adopted so assiduously by the public have meant that so far we have managed to suppress the virus, and the anticipated surge has not occurred in the manner we all feared. On the 27th of March, the NEFID recommended a pause in all non-essential health services. This was for the purpose of freeing up capacity and reducing opportunity for the spread of the disease. As a result, during April, there were up to 2,000 public beds vacant at any one time, which is unprecedented. The level of patients in private hospitals was initially modest. However, the arrangement allowed the HSE to transfer and thereby maintain critical essential services such as cancer surgery and chemotherapy, cardiothoracic surgery and urgent cardiology procedures, as well as providing the assurance that extra capacity was available in the event it was needed, which was the main objective of the arrangement initially. Since then, local cooperation between the public and private hospitals has supported an increase in utilisation, and the latest figures available show that inpatient bed utilisation across the private hospitals is now at 48% of capacity and 56% of critical care capacity. The resumption of routine scheduled care has commenced, and the HSE is continuing to increase its utilisation of the private hospitals for the remainder of the period of the current arrangement. The committee has also highlighted the issue of continuity of care. Faced with the immediate prospect of a major peak in demand for hospital care, the Government mandated the HSE and the Department to procure 100% of the available private capacity for public patients. The agreement provided that all patients treated under the arrangement would be treated as public patients, with care provided based on clinical priority. The arrangement did make explicit provision for continuity of care for patients who were either in the hospital at the inception of the arrangement or who were required treatment during the course of the arrangement. Full-time private consultants were offered locum public-only contracts for the duration of the arrangement. Where a consultant accepted the contract, they would continue to treat the patient but as a public patient. Where the consultant did not accept the contract offered, the transfer of the care of the patient to another consultant at the point in their treatment plan they had reached was to be facilitated. Implementation issues were encountered, and of course, more generally, the pause in non-essential health services, which was only lifted by NEFID on the 5th of May, has affected private patients as well as public. The Department also worked with the State Claims Agency to make available clinical indemnity to those consultants who have not agreed to the contract, such as those providing care for continuity of care reasons to private patients on a pro bono basis, subject to the agreement of the hospital concerned. In conclusion, the arrangement with private hospitals was developed in very quick order in exceptional circumstances. It met its urgent objective of ensuring additional capacity was available in the event that the public system was overwhelmed, and supported the maintenance of other urgent critical care such as cancer services. The public system faces ongoing challenges as we endeavour to resume operations in the context of Covid-19. The capacity within the private sector is an important feature of Ireland's healthcare infrastructure. It has a role to play in meeting the challenges we face, in continuing to be prepared for any subsequent wave of disease and for meeting ongoing healthcare needs. Government is currently reviewing the current arrangement, and as deputies will be aware, on Friday announced that the current arrangement would cease at the end of June, and the Department and the HSE were mandated to open up negotiations with the private hospitals to put an alternative arrangement in place. Thank you.
Thank you, Mr. Breslin. Mr. Woods, may we have your opening statement, please?
Thank you. Good afternoon, Chairman and members of the committee, and thank you for the invitation to attend the committee meeting. I'm joined by colleagues Ms Angela Fitzgerald, Dr Vida Hamilton and Mr Ray Mitchell. I intend to go through a summary of the statement, Chair, to allow for time for questions. In March 2020, the Government approved a proposal from the Department of Health to allow for formal partnership with private hospitals, which would make their facilities and capacity available to meet the challenges of the Covid-19 pandemic. This put over 2,200 beds, approximately 8,000 staff and a range of clinical facilities at the disposal of the Public Health Service. A number of other countries had made similar arrangements, for example UK, Australia and Spain. By decision of Government, the arrangement is now ending with a view to negotiating a new one going forward from the end of June. We will look forward to working with
Mr. Woods,
to negotiate a new arrangement.
Excuse me, Mr. Woods.
Yes.
I wonder, could you mind just speaking a little bit closer to the microphone? It's just a little hard to mind.
Is that better now?
I think that's much better. Thank you.
Thank you. The Government decision to acquire access to the total resources of the private hospital sector included a number of key principles. Private hospitals would operate on the basis of public-only work. The basis for funding the hospitals was to be through a cost recovery model. Private hospitals would focus, initially at least, on delivering time-dependent care. Private-only consultants associated with the 18 private hospitals to be offered temporary consultant contracts for exclusively public work, and the public hospital system would continue to operate under existing eligibility rules. In terms of the clinical context, clinical modelling exercises undertaken within the HSE in March 2020 regarding the expected demand for acute care and critical care arising from the pandemic indicated that by mid-April we might possibly require up to 1,000 critical care beds and 2,000 additional inpatient beds to meet peak demand. Existing public sector capacity was 250 critical care beds and 11,000 inpatient beds, operating at close to 100% occupancy, with 650 unavailable due to delayed transfers of care. The timeline was pressing and the options available to ramp up short-term capability were limited. As a consequence, we secured the Government decision and agreement outlined above. On the 27th of March 2020, NEFIT directed that all non-essential surgery, health procedures and other non-essential services be postponed. As a result, all public and private hospitals curtailed their elective activity during April in the interest of patient safety and protecting capacity for surge requirements. Approaches to boosting acute activity were primarily to stop all non-urgent elective work, to grow critical care capacity and to acquire private hospital capability. And the experience to date has shown that private hospitals do not, generally speaking, employ consultant specialists who work with them. They are served by either public appointment holders with private practice rights or by a group of private-only consultants who do not have public appointments. The number of private-only consultants is in the region of 550. Of these, 291 have taken up the offer of a public patient-only contract from HSE, a Type A contract, and are treating public patients on private sites. A key concern identified was the imperative to ensure continuity of care for private patients. The HSE fully acknowledges this requirement, and where there is a justifiable case based on continuity of care needs, we have agreed that private-only consultant rooms can be included in the initiative as a recoverable cost. The HSE agreed a range of measures to ensure continuity of care, including private patients who were in course of treatment at the date of the arrangement commencing will continue in care. Patients who were booked for procedures based on clinical priority were to be admitted as public patients without charge. Some consultants offered to provide care pro bono to ensure continuity of care, and both the HSE and individual consultants have a duty of care, a duty to ensure care continuity, and this occurred. Consultants from public hospitals provide care in private hospital settings today, and indemnity cover was provided. In terms of future considerations, until such time as there is a vaccine or a cure for COVID-19, healthcare delivery will occur in a higher risk environment where outbreak and surge could occur at any time. The underlying capacity issue remains in the acute system. This is amplified by the need to manage in a COVID environment. The private hospital system is not the sole solution for the safe delivery of care in the COVID environment, but it is the only immediate acute option that can help provide an occupancy of 80%, delivering on the twin requirements of matching non-COVID demand and providing surge capacity for COVID-19. Against this backdrop, our objective remains, as set out earlier, to provide a capacity reserve against surge pressures, to maintain essential services to non-COVID but time-dependent surgery and treatments, and to ensure safe environments for both patients and staff, and to address the extensive build-up of displaced work as soon as possible. Some of the innovation undertaken in the last 2 months will need to stay in place. Virtual clinics can support and the delivery of up to 50% of outpatient appointments in some specialties, reducing the requirement for face-to-face appointments. In summary, I would say that all the indications are that the pandemic will remain a significant shaper of health and services for the medium term. The basic shortfall in acute capacity is an issue we need to address, along with COVID-19.
Mr Woods, I'm sorry, I'm going to have to interrupt you there, just in the interest of time. I appreciate you were giving a summary.
Thank you very much.
Thank you so much. I'm now going to move to remind members that they have 5 or 10 minutes for questions and responses from witnesses, and I'll be keeping you to your time and allow you to come back in a second time. We're starting with Fine Gael this afternoon. Is it Deputy O'Dowd first? Are you taking 10 minutes?
I just want, first of all, to deepest sympathy to the families and all those people who lost family members as a result of COVID-19, and it's hugely important to acknowledge the pain and the suffering of all of those people, and also in the context of the hospitals, be they public or private or indeed nursing homes, the fact that all of the people who worked in them have put their lives on the line, their health on the line, and it's very sad that thousands of people actually caught the illness as a result of the work and their commitment to the people. So just the first point I want to make, if I can address it to the Secretary-General or Mr Woods, I think the expectation at the peak, at the very beginning, was that you could have, at the very worst scenario, we could have 120,000 people a day being actually diagnosed with COVID-19. And was that really the reason that you did the deal, which I fully support, that you took on 100% of the capacity of the private hospitals to deal with those potential patients if that awful apocalyptic number actually happened?
Yes, very much so, Deputy. And it wasn't just that this was modelled, this was what we were actually seeing within our hospital services. So I mentioned that in the opening statement the figures for ICU. Within the space of a week, the numbers in ICU had doubled up to 111 people in ICU. And actually over the next 10 days, that's when the deal was done at 111. Over the next 10 days, which is still within the incubation period for the virus, that went up to 160. So we were on a trajectory that was going to see ICU capacity run out. Two things happened. We took public health measures, and the whole of the country took them, and assiduously implemented them to interrupt the virus. And that managed to dampen the slope of the curve that we were facing. But we also had to put contingency in place. And the most immediate and the most available contingency was in the private hospitals. There were 100 critical care beds in private hospitals, and over the space of a weekend, officials in both the department and the HSE, with the full support of the Private Hospital Association, put together an agreement that allowed the public access to those facilities if COVID-19 took us to the place where none of us wanted to go.
I think, therefore, my comment would be that the actions that you took were appropriate, were fit for purpose if the worst ever happened that could happen, and that it was prudent and right that you did that. And I want to make it exceptionally clear that I laud and support fully all the actions that the HSE and the Department of Health did take, and that and I think that was acknowledged by everybody. The issue that arose here this morning was a question of the spare capacity when that day didn't come, thank God, due to the action of the public and the health workers and all of us. When that didn't happen, then there was a spare capacity in the acute, in the public hospitals and in the private hospitals. And I understand it, as I understand it, on the 27th of March, NEF had made a recommendation that all non-urgent scheduled care be postponed, both for safety reasons and to avoid the spread of COVID-19. So in actual fact, a significant portion of the bed capacity that could otherwise have been used couldn't actually be used because of that directive. Is that a fair comment? So is it fair to say that whatever issues are building up now in terms of backlogs, which are very significant, that it was a result of a medical or a medical opinion that you couldn't actually put patients into those beds at all? It wasn't the appropriate or proper thing to do.
I think we have to unravel two things that happened right at the same time. And the underlying cause of it is the same thing, but there were two completely separate things. Because of that exponential growth, NPHET took the public health advice that they would advise all non-essential healthcare services to pause. That included private, public and private, non-essential healthcare services should pause. And that was on the 27th of March, and on the 30th of March, the deal with the private hospitals was completed. Why did NPHET make that decision? They did it for two reasons. One was to ensure that we had space for the surge when it came, but secondly, in recognition that the spread of the virus within the community was such that there was a risk of bringing people in for non-essential healthcare that you would further spread the virus. And both the public and the private hospitals experienced that over the course of April. I've mentioned in my opening statement there were 2,000 beds vacant in public hospitals at one point, which is absolutely unprecedented. So undoubtedly, and there is learning, there will be learning for the next arrangement that we enter into, undoubtedly there were complications in operationalising this arrangement with 18 different hospital groups with over 500 self-employed hospital consultants. There's lots of learning. But the biggest factor in the utilisation during the course of April and into the early part of May was that NPHET had not lifted the pause on non-essential healthcare during that period, which meant less uptake of healthcare. And in fact, when we surveyed the public during that period, 28% of people say that they delayed accessing healthcare during that period. We don't like that. We've tried to get that message across that you should seek out healthcare, but the public were naturally anxious about it too, and both the public and private systems experienced that anxiety.
So then the charge that's made that it wasn't value for money, but it was there if it could be used. That's the first point. The second point, it was a value on the lives of all those people who could be put at risk if they actually caught the illness. And that's why I think that the criticism is misinformed in that respect. But the question I want to ask you is one which affected some of my constituents. It's the contract which consultants were asked to sign. Now, I appreciate and support the fact that all work was public work in public or private hospitals, and that the income a consultant would get couldn't be greater than the public pay. But the question that arose, and I think is a key point which must change, is that if I was, say, a consultant of long experience, I might have, say, 3,000 patients, and I had always maintained them with my own secretary or PA, and also with my rooms. Now, and I think that is it fair to say that I think it's fair to say, rather, that you need to look again. Should that happen? Should we have a return of this evil virus? That you need to be able to meet the real costs of a consultant who has to manage his caseload. As one said it to me, it's like an iceberg. The tip of the iceberg is what's in hospital. All of the other people are outside. You have to meet them regularly. You have to look after the communications. You have to look after the appointments. You have to look after the staff. And do you think that you ought to reconsider that issue now, in the future, that a consultant would be recompensed for those real, tangible, provable additional costs which in the public sector don't apply? The consultant in the public sector, he has all the backup of the hospital, he has the administrative staff and all that. So do you think that's an issue that perhaps everybody could work on constructively?
So I think if you look at the phases of this arrangement, I would see Plan A or Phase A being when the surge was imminent. I would see Plan B being when that surge didn't materialise, and the efforts of the HSE to ensure that we got other priority work through those hospitals. And if you look at Plan C is from last Friday, where we're going to enter into negotiations on a new arrangement. The government said to us in respect to Plan A that should be public only, and there was a rationale to that, which was If we all had the virus, were we going to have different access depending whether we had private health insurance or not? So there was a legitimate policy rationale that was provided at that time, and that's the arrangement that was put in place. When it moved from the surge into routine, essential treatments and more routine treatments, then one of the issues that arose was continuity of care for private patients. And we were still able to say to consultants that those patients can be treated, but as public patients. Consultants then said, we have rooms that bear costs that we have to fund, and what's the position in relation to those rooms? And with the HSE, we put an arrangement in place where those rooms were needed for the purpose of continuity of care. The HSE could enter an arrangement to have the use of them and pay for those. But this was very much, as we moved along from Plan A to Plan B, and where we go next will be Plan C, which I think will be different. It will have a stream of public funds going in, but it will also see again the private health insurance money come into play, but with the protection that if we have a surge, that we're able to take over 100% capacity again. So these are all decisions that are being made in real time, and I don't see it as an issue that you change your position as something changes in the environment within which you're dealing with. I think that was the right thing to do at every stage.
Just very quickly, the question of IT was mentioned by one of the consultants that I think it was in the mental health area, that they don't have computers, they don't have technology. So can you address that issue? Can you make sure it is addressed that that doesn't continue to be the case?
Definitely, I'll address that. Thank you. So in terms of monitoring the work that's being done in private hospitals, the HSE, with the support of the NTPF, have put in a system for precisely that purpose. And that was one of our early objectives, was just to record the work that was actually taking place. And we've enabled that, and we have supported that with the implementation of a system. Were there to be other system requirements as we move this forward, of course we'd address those in dialogue now about the arrangements post-June. Thank
you very much. Now we've Fianna Fáil, and I believe it's Deputy Butler first, followed by Deputy Donnelly.
Yeah. We all understand the rationale behind the decision to take over the private hospitals at the start of the COVID pandemic. However, as a committee, the onus is on us now to look at the COVID response and learn as we face the possibilities of a second surge. Mr Woods, you referred to the fact that of the private-only consultants there was 550 and that only 291 signed up. Many consultants who contacted me, and I know contacted all the members of the committee, were disappointed that they were only offered a Type A contract. Why was the option of a Type B or a Type C contract not offered?
In the early stage of this, as was stated by the Secretary-General, the decision of government was that there would be a singular response to what was a clear and pressing public demand, and that included a Type A contract, which is a public-only contract. And that is the contract that the consultants I referred to signed up to. It was voluntary, of course, to sign that, and a significant number of consultants chose not to. So they had the capacity to continue their own outpatient practice outside of this arrangement.
Thank you. Mr Breslin, you referred to the fact that there is learning for the next arrangement. Was any consideration given to the long-standing patients currently undergoing treatment and being treated by private consultants, especially those who need regular consultation? Because we've all been contacted also by many private patients, and we know there's 2.2 million private patients in Ireland at the moment, and a lot of them felt they needed ongoing treatment during March and April and May. And I do accept it was an unprecedented pandemic, but at the same time a lot of these patients felt that they were forgotten about. I know all the focus had to be on COVID, we all accept that, but as you said, when we're learning for the next arrangement, could more consideration be given to these patients, especially those with oncology issues?
Deputy, and indeed in my opening statement I referred to implementation issues which I think are available to us in constructing the next arrangement, that we would learn from that. But just to emphasise that from the outset continuity of care was a really important objective of all of the parties that sought to make this work. It was provided for in the heads of terms with the private hospitals in two respects. One in respect to there were patients on the day that we entered into the arrangement, there were patients in the hospitals, and it was important that they had continuity of care. But there were also patients that were undergoing a treatment plan with a private consultant. And the arrangement in that case was twofold. The ideal situation was the private consultant signed up to the contract that was offered on an agreed basis, in which case they could continue to see all of their patients under the new arrangement. The only distinction was they couldn't charge them a fee, but that patient would still get continuity of care. In the event that, and 291 consultants signed up, in the event that a consultant didn't sign up, then the option was, for some people, they might wish to stay with that consultant, but if they wanted, for example, to be admitted to a hospital, a private hospital, they would need to be admitted under the care of another consultant, either an existing public consultant or one of the consultants that had signed up to the private arrangement, in which case their continuity of care would be facilitated by a transfer at the point in the care that they were, not going back to their GP and starting from scratch, but at the point in their care. Now, there were issues that arose with that, but that was the clear objective that we all sought to try and bring about.
Thank you. We learned during the opening statements that between 44% and up to 50% of private hospital capacity was utilised over the last couple of months. Now, we learned last Friday that the arrangement will not continue. Is there any plans by the Department or the HSE going forward now to utilise as much capacity as possible during the month of June to tackle some of the extensive waiting lists that are out there?
Thank you, Deputy. So I think, as the opening statements indicated, the decision of NEFIT was effective up to the 5th of May, and from that time we've been growing throughput into private hospitals significantly. At this stage, in terms of daycare, in fact, it's at 150% occupancy, so 1.5 patients per day, and in terms of inpatient beds, it's at 50% occupancy. So we do intend to continue to grow that, and as part of the dialogue around any new arrangement, we would look to ensure continuity relating to that. So there is a clear intent to get value in the month of June. We will also remain alert to the trends that emerge in terms of the OR statistic as we move into the following weeks, and hopefully that remains where it is, which is at a very low level. But we need to be alert to the fact that should the data move, it will place significant demand on the acute system again.
Thank you.
Deputy Donnelly.
Thank you, Chair. I'd like to thank our witnesses. I'm going to start with two questions. I believe it was exactly the right decision at the start, but I believe the secondary rationale, which was around maintaining capacity, really hasn't worked at all. And my view is it should have been ended as soon as it became clear. At the moment, we are essentially using public money to treat private patients in private hospitals by private consultants. My first question is, why aren't we just using the public money to treat public patients with the spare capacity and let the insurance company continue to pay for the ongoing work for private patients, which is still happening anyway? My second question is, why we didn't end the contract sooner. I understand that the contract was up to the end of June, but all contracts can be negotiated by agreement, obviously. It was estimated this morning in committee that the ongoing reduced capacity in the private system just for June will mean that about 10,000 men, women and children do not get surgery under general anaesthetic, public and private, which is an enormous human cost for continuing with what we know is a contract that isn't working. Can I ask, did the department engage with the private providers to see if this could be, if the contract could be wrapped up sooner, given that clearly it isn't doing what we all hoped it would do?
On the first question, Deputy, regarding private patients, again, I go back to where we started from, which was that all patients were considered public patients, and that is the legal position. Every patient in the country, every person in the country is entitled to be first and foremost a private patient, a public patient. They get to opt out of that and waive their entitlement if they wish to, but including people who have health insurance, they're entitled to be public patients.
Mr. President, sorry, that really doesn't answer the question. I don't think there's too many private patients in the country looking to waive their private patient status so that they could become public patients and not get any treatment with respect. The question I'm asking is, Why not let the private patients continue to be paid for by the insurance companies, which is what would have happened, leaving all of the money to be deployed for use exclusively with public patients?
So what I was trying to go on to say was that that was the rationale of the arrangement, if, as I've described it, Plan A, which was that if we single tier, everybody in the situation of a pandemic would be treated based on clinical need, and there wouldn't be two streams of income going into the private hospitals, one from the public purse and one from the private. The plan has changed, and the government on Friday has opened up now the possibility of us putting an arrangement in place where we would only pay for public patients.
Sorry, Mr. President, I understand that the question I'm asking you is why. You're restating what happened, which is everyone was to be treated as a public patient. I understand that. The question I'm asking is why. For people who get COVID, absolutely. Makes perfect sense. But for all of the ongoing treatment, if insurance firms are willing to pay for the private patients, and maybe they don't get priority during the crisis, I'm all for that.
Let me try.
Why use public money to pay for non-COVID healthcare for private patients in private hospitals?
Let me try and give you further insight. There was the principle of the matter that if we were facing the kind of overwhelming surge that was going to take place, that it should be public and single tier. There was also the practicality of the matter. None of us knew exactly what that would look like during the month of April. And what was put in place was a cost-only reimbursement model, where the costs of the hospitals was reimbursed. The difficulty in that situation where you had cost recovery for all of the costs within a hospital, of disaggregating out how much of that then was being incurred by private health insurers and private patients, would have left us all with a situation where quite legitimate questions could be asked as to whether the public money was going in and was benefiting public patients or cross-subsidising private patients who were continuing to have preferential access into what was now fully publicly funded facilities.
I guess the problem is that might have been the concern people have, but that is exactly what has happened. That's the entire point of my question. In fact, that became exactly what happened, is public money is being used. But can I just, because we're running out of time, can I just get an answer to the second question, which is, did the department engage with the hospitals to look at ending this earlier than the end of June, given that there is a vast human cost to keeping this contract in place?
I'm not certain that the discussion this morning on the 10,000 fully appreciates just how difficult it will be to bring back up to normal levels, either public or private facilities. There is no doubt that there will be issues in terms of getting back to the kind of activity levels that we may have seen in the past, not just in the public system, but in the private system. To your question on whether that was done, the options that were looked at was whether there would be an extension to the end of August, which would allow those negotiations to take place across June, July or August, or whether the HSE would terminate the arrangement at the end of June, leaving us with the next 4 weeks to put in place an alternative arrangement that will continue to see public patients access those facilities.
So no, just to be clear, nobody asked the private hospitals if they would be willing to end earlier than the end of June.
Thank you, Deputy. We're at the end of our time, and I don't want you to take from Deputy Coleman's time. Deputy, are you taking 5 or 10 minutes?
10 minutes, please. Thank you, Cathaoirleach, and can I welcome again Mr Woods and Mr Breslin. Can I thank you both for your service, and also to all of your staff, especially you, Mr Breslin, and the HSE, all of those working across our acute hospitals. I want to send them my solidarity greetings at this time. If I can start with you, Mr Breslin, first, because I read your opening statement with interest, and the first question I have is, do you have at this point in time the all-in cost for the private hospital agreement? So is there a figure that we can now have at this point in time, this is the all-in cost?
And Mr Woods will have them. We have the cost up to the...
I just want the cost first. That's all. I don't want to be rude. I'm just asking for the cost. If the cost is there, if I can have that.
You have a choice of the cost up to today, or you have the projected cost to the end of...
Both, please.
Maybe Mr Woods would.
Oh, thanks, Jim. So, Deputy, the cost up to the end of April was 97 million, and the cost is based on what work is actually getting done, so it will vary slightly, but it would appear that it's going to be between 97-100 million per month. So, in estimate, that's where it is, but they are estimates. The first cost is based on a validated figure.
So, are we talking about in the region of 300 million?
That's right.
Okay. And you would have heard, or have you, or did you hear this morning, Mr. Breslin, if I can come back to you, the testimony from the both the IMO and the IHCA, and if I can paraphrase the IHCA, they said pretty much that this deal or this agreement was a bad deal, that it was bad value for money, and there was no plan for underutilised capacity. I'm assuming, given that I read your opening statement and I've heard what you said, you don't agree with that. Don't agree, okay. And Mr. Varley went on to say, and Mr. Varley is the head of the IHCA, that, and I quote, "The test of time has confirmed that the private hospital agreement, which is costing €115 per month, represents poor value for money from patient care and taxpayer perspectives." Again, I assume you don't agree with that?
Can I tell you why?
Well, we'll get to that in a second, but I'm just, if you don't agree, I'm assuming first.
I don't agree.
Okay. And he went on to say that the private hospital contract prohibited the provision of urgent care required by patients with non-COVID illnesses. Again, and I've read your opening statement, you don't agree with that either?
I agree with that.
Okay. So, can I first of all ask, and we'll go back to the nuts and bolts of this agreement and how it was negotiated. Who's involved in calculating the cost and also negotiating the deal from the state side? So not individuals. Can you tell me what state actors, what government departments and organisations were part of that negotiation process, please, very briefly?
So government provided a mandate, a set of principles that would be used by the negotiators, and the HSE, with the support of the Department of Health, negotiated intensively with the Private Hospital Association.
So it was the HSE and the Department of Health. And who carried out the cost-benefit analysis, or was there a cost-benefit analysis?
So there was input from across government. The NTMA New Era gave us some input. The Department and the HSE looked at it, and we came up with what is a cost recovery model rather than a fee per item model. And part of the thinking behind that was there was so much uncertainty looking into April as to what actual services would be required. Had we got it wrong, there could have been huge profits.
Was there a cost-benefit analysis carried out?
No, there wasn't a full cost-benefit analysis.
There wasn't?
We didn't have access to private hospital costs at that stage.
But you were the one negotiating a contract with private hospitals. I'm assuming that you would have sought those figures. Why weren't those figures available? Because when we get into the nuts and bolts and the fundamentals of this deal, the deal was with private hospitals. And you know, and we soldiered many times on the Public Accounts Committee, the CNAG will always say cost-benefit analysis is hugely important when we're taking big decisions that cost the taxpayer a lot of money. Now, there may well be a good reason why that was not done, and you can answer it, but what you're saying to me today is, in terms of this negotiation, there was no cost-benefit analysis carried out.
Oh, so there was an options appraisal. We looked at different means of securing this capacity. A full cost-benefit would ask the question, do you really want the capacity or not? That question was answered for us. We were staring that in the face every night on the 9 o'clock news as to whether we needed this capacity or not. The next question then was, what are the options for securing that capacity? And we did an option appraisal on the different types of options that might be needed.
Okay, so I get that. So there wasn't one carried out. Can I ask if the Secretary-General, if the Department of Public Expenditure and Reform...
I could just finish. What was put in place then was a cost recovery model, where on an open book basis, the private hospitals have to produce their accounts to show that they've incurred the cost.
And you said that 3 times now, so I accept that.
And it is open to the CNAG to audit those costs as well as the HSE's advisors.
Yes, and that's the 3rd time you've said that, but what I'm trying to establish is that for the reason that you've outlined, there was no cost-benefit analysis because, as you say, the decision was made to do it, but there still could have been a cost-benefit analysis of sorts in terms of the fundamentals of the cost. So I just want to get to that. And first of all, before I get to that, can I ask, did the Secretary, sorry Mr President, did the Secretary-General of the Department of Public Expenditure and Reform sign off on the agreement?
So I would like to answer the last question that I didn't get to finish, and that's to say that this was negotiated within a matter of days, basically over a weekend, and I think that is an important factor. The Department of Public Expenditure was involved in the submission to government on this, supported the access to these facilities, and supported the financial model that was used. The costs.
Did they sign off on it?
The government signed off on it.
The Department of Public Expenditure, did the Secretary-General of that department
But there's no
any role in signing off on this.
No, a Secretary General or a department are not independent of the government.
I know that, but what I'm asking is that they are the ones that were the national the procurement agency is under that department as well, and we know from other big projects that where there was mistakes made in the past that the role of the Department of Public Expenditure and Reform is very important. All I'm asking you is that did they have a formal role or not in signing off on this process? If not, if it went straight to Cabinet and they signed off on it, that's fine.
No, it didn't go straight to Cabinet. The Department of
so they didn't.
gave us their advice and we adopted the advice on the financial model. It was consistent with our own thinking.
And when you were looking at this agreement, what percentage of capacity in private hospitals did you lock into that plan? So what percentage capacity of private hospitals did you anticipate you would use over that 3-month period?
Well, so that was the real uncertainty we faced. We at the start considered that we would probably need it all and more besides.
You didn't use all of it. You used maybe less than half.
Other countries, if we had the ICU admission rates that other countries have experienced, we would have needed it all.
Well, what I'm saying, so at the time, so I can understand this, so in real time, when you were negotiating this deal, it was on the basis that you anticipated using the full capacity in private hospitals, is that right?
We anticipated we potentially might, and we didn't want to be in a situation where we didn't have access to it.
So when you were negotiating the deal, did you then look at a like-by-like cost analysis of a bed, for example, in a public hospital and a bed in a private hospital? So in terms of this particular deal that was negotiated, what was the actual average cost of a bed in a private hospital in the context of the deal, which we now know will cost €300 million, and what was the average cost of a bed in a public hospital?
So we do have average costs for public hospitals, and based on the information we have from the private hospitals, quite a number of them would be more expensive than public hospitals. So we are paying more in that situation.
But you were negotiating the deal, Mr. Breslin.
Can I, if you give me a moment just to answer. We didn't have any other beds. We had all of the public beds that we needed. There were no other beds on the island that we could get access to. So getting on a cost-only basis was actually the most economic thing for us to do. If there were cheaper beds out there, yes, we could have got them, but there weren't. These were the only beds that were available to us, and we did it on the cost.
And I should point out to you, Mr. Breslin, that on many, many occasions it was pointed out to you by all of the organisations that were here this morning and by people outside of this room as well, that there wasn't capacity in the public system, that we needed more beds in the public system. So the very fact that you had to go to private hospitals is testimony of the fact that we didn't have capacity in the public system. But what I'm saying is, if you're negotiating a deal and you're coming up with a price, because I worked in the car sales industry at one point, and I can tell you, I would love to see people like you coming through the door when I was selling a used, or if I was selling a used car, because what I'm trying to establish from you is, when you were negotiating that price, surely you would have had an estimated cost of what a bed costs in a public hospital as opposed to what the cost was going to be in terms of this deal for private hospitals.
Yes, I've told you that we.
Oh, but you didn't give me the cost. So what was the cost per bed in terms of this deal in private hospitals? What was the actual cost per bed as opposed to what it is in the public system?
We won't know that until we have all of the costs verified from the private hospitals. We are not paying them a fixed amount of money. We're paying them what they actually incur in terms of costs. So the validation and verification process will be done by a team of accountants to come up with what that cost is.
Well, it strikes me, Mr. Breslin, and I do accept what you're saying in relation to they were the only beds out there. It was the obvious place you were going to go to. But I am long enough around to know, from my time on the Public Accounts Committee and my time in terms of looking at what's transparent, what should be accountable and what's value for money, that a cost-benefit analysis is important, having the fundamentals of a deal properly examined is important, and it doesn't strike me on this occasion that this happened. Now, you've given what you see as logical reasons why not, but the fact is this deal cost us €300 million. You said that you anticipated that you would use full capacity. You used less than half the capacity. And I put it to you again what was said by the ICHA, that this wasn't a good deal, both in terms of patient care and taxpayer perspectives. It's hard to disagree with that, given that there was no cost-benefit analysis and you only utilised less than 50% of the capacity.
I tell you what that sounds like to me. That sounds like a fire alarm went off and we sent 4 fire tenders to put out the fire, and people are now saying we only should have sent 3. I'm very happy that we sent 4 fire tenders, because what if it needed more than 3?
Thank you. Thank you, Mr. Breslin. Thank you, Deputy Cullinan. Now, Deputy Noonan, you're joining us. You're very welcome. 5 minutes, I think.
Thank you. Just a number of questions, if that's okay. Now that elective surgeries have resumed, there will be a roadmap soon outlining the return to normal healthcare services. It's important that both public and private open in tandem. Can you outline what elective services have resumed and the breakdown between private and public patients being treated is?
Deputy, I'll take that. You're right in saying there is work going on in terms of a roadmap to recommence what were described as non-essential services, which are being resumed right now. So in the public system, there is a resumption of some activity. And maybe just to say what we've seen is a significant fall-off in elective activity, both by way of the decisions we've already spoken about and indeed the public's attitude in terms of attending healthcare facilities. So what we're resuming now is surgery such as orthopaedics. Rapid access cancer services continue to run, and we're looking to grow the volumes through those. We've directly gone after growing the numbers of cardiology and stroke attendances because we've seen concern around that. And general surgery, to the extent we can resume it, is resuming. I think it's important to note, though, and it was referenced already in dialogue, that the capacity to do work within the current environment is more restricted than it was before we had COVID, and so our throughput capacities will be limited. In terms of the private system, as you've referred to it, the NTPF have obviously got cases identified for priority treatment, and they can be targeted to the private system. The private system is already, and have been, the private system is already doing cancer work for the public services. So we had moved cancer work from Mater and Vincent's. In Tralee, there's a joint roster working around key areas of provision in areas such as general respiratory care and indeed rheumatology. So we would anticipate that the caseload within the private system for surgery will also grow in the coming month, contingent on what happens, the figures around the trend in pandemic. I think the key point to get across, though, is the challenge of operating in both environments is very different to what it was if we go back 3 to 4 months.
Thank you. Second question. It's obviously not cost effective to be buying out private hospitals and consultants every time that there's a surge or another medical emergency, a national medical emergency. So what is the long-term plan to prepare for the next medical crisis? I think I need her to.
The point about the next set of negotiations are with the private hospitals, which is not the only response in capacity terms, and I can talk more about that, will be for a more medium-term view. I mean, we have to look at the coming winter, getting through that winter, the risks associated with COVID and flu being present, and the demand on capacity, which we know is already constrained and at the moment running at 92%. If we were to return all the work that is currently being done in the private system to the public system, that would immediately drive the public system toward 100%. So the strategies we have to follow, and some of the innovation that took place while COVID was very present with us, and it remains so, in areas like outpatients and indeed emergency departments, we have to continue some of those innovations to, in effect, reduce the footfall in hospitals, grow the amount of work done in the community in primary care environments, and that will include the provision of diagnostic and other services in the community. And we're also looking at a range of activities in what will be referred to as intermediate care provision between the GP and the hospital. So we will have to, and they would very much be aligned with the kind of recommendations coming from the Sláinte Care report. And so we will, and we are working to actively develop those kinds of arrangements right now.
Thank you. Was there a mechanism by which you could transfer patients of consultants who did not sign the contract onto the public waiting list? And what is happening to these patients now once this deal is over?
So consultants who did not sign the contract, if there were patients who needed priority clinical care, then that care was provided, and actually very often by those consultants making arrangements with other consultants who had signed the contract. I had come across that myself, and I think when you had the IHCA in this morning, they had indicated that consultants did that to ensure continuity of care. Those patients who are already in effect in treatment would continue in treatment as clinical priority. New patients coming in who are private will go onto a common waiting list by facility. That's the normal rule set within the system.
I have a time for a question.
Very quickly, please.
Yeah, it's just the government says the deal is ending, but if there's a surge or another surge is extremely likely, and the private hospitals would be needed again, what are your recommendations for ensuring continuity of care of the both public and private patients and continued operations of general operational services should this occur?
So I think the key challenge, Deputy, for us is that the demand for emergency care through the ED department, which is the largest by far element of demand for inpatient care within our system, and what happens that demand as we move toward winter is the key determinant of that. And we have had to constrain elective capacity for reasons of pandemic, and we have also seen a fall off in emergency attendances. So as they return, and they are, those figures are rising now, which is a good thing, we have to plan on the basis that we need to retain some empty space to allow for safe care provision within hospitals. And I think when we look to the future and you ask what are the recommendations around that, it is really to say what is it we need to do and what do we recommend to keep the system at an 80% occupancy.
Thank you, Mr.
across the
Woods.
full system.
Don't mind, I'll have to move on to Deputy Shorthall. Deputy Short, excuse me. You're quite right. Excuse me, Deputy Smith.
No problem. Thank you, Chair. Mr. Woods, thank you. First of all, I'd like to thank all the witnesses for their statements and contributions so far. Look, I was taken with this penultimate page of your opening statement when you said your objective remains as set out earlier, to provide a capacity reserve against surge pressures, to maintain essential service to non-COVID but time-dependent surgery and treatments, to ensure safe environments for both patients and staff, to address the extensive build-up of displaced work as soon as possible. Is it fair to say that the HSE would have liked to have seen this contract continue?
So this contract was, as has been previously indicated, an emergency response to a rapidly emerging situation. So, and I think it is right, as the Secretary-General reflects, to think about phases. There were deliberately flexibilities within the contract allowed for a review and a break at the end of June and further deliberation around that. So I think from our point of view, it makes sense, and we would welcome the renegotiation and working with the Private Hospital Association around a renegotiated arrangement. It doesn't have to be precisely like this one, but the capacity is clearly relevant as we move toward winter.
Okay, so you essentially want now a renegotiated contract, a stronger contract. Are you, or I don't want to put words in your mouth, are you confident in two things, that A, in the next few weeks while this contract runs down, that the pathways are there to use the capacity to a greater extent than it has been used thus far? And second of all, how confident are you that the next contract will meet the needs that the HSE want in terms of their relationship with the private hospitals?
So the occupancy has been growing, as I indicated and you referred to in my opening statement, and that has been, since the 5th of May, since the NEFIT decision has reversed, that has been a priority for us. And so the number of patients going through private facilities has been growing, and we will look to continue that through to the end of June, and indeed beyond, based on a new arrangement. The total requirement for healthcare is increasing. You know that, and that's very clearly documented pre-COVID, and COVID brings some new and urgent requirements around providing care. So I think as we look forward in the HSE, we're looking at winter, we're looking at a time period that goes beyond the end of August in any event, and so we've got to look through to March next year and make sure that we have plans in place to address what will happen over the coming winter.
Okay. Would the HSE be in favour of purchasing one or two private hospitals? Wouldn't that be the quickest way to get more capacity in the public setting? Has that been discussed? Has it been costed at any level in senior management of the HSE?
I've had no dialogue about the purchase of private hospitals. In fact, the fastest response for us in terms of the pandemic was to get access to use the hospitals, and that was done through a cost-based arrangement, as has been previously discussed. So the notion of acquiring or otherwise private hospitals wasn't part of our early discussions, because time was not our friend in terms of having arrangements in place coming out of the end of March.
Okay. And just in terms of screening services, is there any kind of indication that can be given to the public in terms of when screening services are going to come back, and be it the capacity the last few weeks of this current contract, or will it form part of this renegotiation with the private hospitals for the next phase? Is there anything that can be given out there to people who are looking for these services?
So what I would say, Deputy, is they're not directly connected. I mean, the point is a well-made point, and it's a priority for the HSE to recommence screening services, but they're not tied into the hospital arrangement. I think there are other clinical priorities around the return of screening, and our Chief Clinical Officer has addressed that previously. And so the priority is to make sure that it is safe to resume screening services, but it's not tied into the private hospital arrangement. That's about planning services in the new COVID environment, and it's a priority for us that screening services do return.
Okay. And just finally, what's the status of the City West Hotel at the moment in terms of that arrangement, and is that being used to its full capacity? I know it's not a private hospital arrangement, but it's just something that keeps cropping up.
There's two dimensions to City West. There is a hotel piece where accommodation is being provided for staff members and indeed patients, and that is occupied, and the level of occupancy I don't have in my head, but it is occupied. And separately there is the conference centre, which is set up as an in excess of 300 bed facility, which was put in as, again, surge capacity to meet what was then an unquantifiable demand as we moved toward a peak in mid-April. At the moment, that facility is being closely studied with a view to opening it for clinical purposes associated with post-COVID treatment and rehab care, as well as thinking about the use of the facility for outpatient facilities, because the required space for outpatients going forward is in fact going to be much greater than what we currently have. Even with the strong use of virtual clinics, we had over 80,000 virtual appointments completed in the month of April.
Right. Thank you, Mr. Woods, and thank the witnesses. And just say that we're delighted that there was 4 fire engines sent instead of 3 in terms of this crisis. Thank you.
Deputy Shorthorn.
I'd join with that about the fire engines. Thanks for your presentations. People were talking about lessons learned. I suppose the bottom line from all of this is that our public health capacity is woefully inadequate, and responsibility for that is entirely political. I have 2 questions, the first for Mr. Woods and the second for Mr. Breslin. Mr. Woods, it's been possible to use capacity for non-COVID cases since the 5th of May. You seem to be very slow at ramping up to using that capacity. And I mean, I know there was some reluctance initially, and people were all the time concerned that we would get the surge, and thankfully we didn't. But at the same time, I mean, there's a lot of procedures which could have been done, say hips or knees, where people could go in for 2-3 days and be back out, and in the event of an increase in COVID cases, you could have cleared the hospitals very quickly. Why are we so slow in ramping that up? And now we're looking at a situation where there's only just over 3 weeks left in the contract, in the current contract to run, and there still isn't a roadmap there. So that's very hard to understand. While there's very valuable capacity in private and in public to a certain extent, and why aren't we maximising the use of that? So that's the first question. My second question then is from Mr. Breslin, and that is in terms of going forward. I think a lot of us would have liked to see the contract continuing, I'd say even up to the end of the year, and that we would use the capacity fully. Because, for COVID patients, everybody got immediate access. So there was no distinction made between public and private. And, there's a strong case for continuing with that kind of approach in non-COVID cases. Sláintecare talked about the importance of having elective-only hospitals, and that's been accepted by government. Have you given consideration to designating certain private hospitals as elective-only hospitals, and really motoring through the waiting lists in those kind of elective surgery waiting times, and making progress there very quickly? And also, I mean, have you looked at the possibility of taking those over on a more longer term basis, as happened in Scotland? Thanks.
Maybe to the first question first, Deputy. Thank you. The capacity question. So since the 5th of May, the priority has been, as you've indicated, to use the capacity to the greatest extent possible. And certainly in daycare, that has worked well. As I was indicating, the occupancy is at 150%. On inpatient side, we're now at actually 54%. And I should point out that so our intention is to grow that. It has been growing. It's come from about 40% to 54%. So we're seeing progress. We would like to see more of that. I think one of the factors that's critical, Deputy, in terms of effective use is the time it now takes to schedule a surgery and post-surgery to make sure that there are appropriate procedures in place in terms of infection prevention and control, is having a significant impact on throughput. For example, the time to operate is leading to places like the Mayo Clinic in the States now running at 60% occupancy. We're at 54. Normally private hospitals would run at about 75. So our objective would still be to push that occupancy up as high as we can using NTPF referred work and also transferring, and there is still work transferring from public to private system. I've referred to some of that earlier. So we will be doing everything we can in the coming weeks to optimise that. And indeed that will inform partly our dialogue around the new arrangements.
Just on the question on elective only, I suppose it does build upon what Liam has just said. Under the new arrangement, we would be focusing on elective. There will be some, such as cancer care relocations and so on, that would be separate to that. But by and large, we'd be focusing on elective. But I think the meat of the question you're asking me relates to a project that we have underway under Sláinte Care, which is that we have fully mapped, assessed the needs and looked at service delivery mechanisms that would say, here's the service output that we need for Dublin, Cork and Galway in particular. We've also looked for other parts of the country, but they're the 3 areas that are mentioned in the National Development Plan. We're now at the phase of moving that into a facility requirement. So we would then put a cost on that facility. If we were to deliver an elective hospital at that scale for those services, what would be the facility required and what would it cost? And then I think we get to the point of making a question to the market, is that a new build or is it a purchase? And I'd be agnostic on that, but it's important that we do the work over the next few weeks to get us to that point.
But purchase is under consideration. It's on the table at least.
Yeah, it'll be one of the options.
Okay. Thank you.
Thank you. Deputy Boyd Barrett, you have 5 minutes.
Jim, would you accept that, that we're caught on the horns of a sort of a major dilemma here, and that we're a sort of damned if you do and damned if you don't dilemma that arises from the fact that entering into this crisis, we had woefully inadequate levels of capacity in ICU, bed capacity, staff and consultant capacity. And that is the fundamental problem, that it was unacceptable entering into this that we were operating near 100% capacity or close to it, and sometimes overwhelmed during flu season with that. And now on top of that, we have for the foreseeable future an additional care need around a pandemic which could surge at any point in time. Unless we dramatically ramp up capacity, we could be in deep trouble in the near future.
So broadly I would, but we're all a bit Irish because we also have gotten through this, and now we look back and say, oh, well, we must have been lucky. We weren't lucky with the amount of capacity we have. We knew on ICU that we had less than the international norms. We knew on other things that we were short. But yet we got through it, and I think it is worth asking the question, how come we have managed? And it is the quality of the staff that we've got, it's the performance of people at the front line, the absolute commitment that people have given to that, and also in the HSE, and indeed I might even mention the department, I might mention the Oireachtas. We did manage to do something right.
Sure, Jim, and I don't dispute that. But we accept there's an unacceptably low level of capacity given the pre-existing challenges, pre-COVID, and now with COVID. Now, and by the way, you might, as a sidebar, the heroic work of our health workers, are the high infection rates in any way linked to the low staffing and capacity levels, which meant they were overworked, working excessive hours, and therefore exposed more to the virus? Because it seemed to me there is a connection. But can I ask, sort of going forward, right? I mean, some in this House have made clear they want to essentially return to the 2-tier system and give the capacity back to the private health system. Isn't that reckless in the extreme, given that we could face surges in the near future? And don't we have to, at least with the limited capacity we have a totally integrated rather than fragmented system? And that means keeping the private capacity under public control. And given that I think that's what we have to have you considered just the outright nationalisation of the private hospitals rather than paying them rent of €110 million a month, which is clearly not very good value?
Certainly looking forward, given that we don't have a vaccine for COVID-19, I think all of us would want to retain a step-in power, a retainer over the private hospital capacity, that if we did get the kind of surge that we feared, that we would be able to move quickly. We would also want to have access to the capacity for priority needs. I think you're bringing me into the policy space when you ask me about nationalisation, but what I can say to you is the Department of Health completed a bed capacity report which said if we do all of the reforms that are in Sláinte Care and all of the changes that we need to do to reform and modernise our healthcare services, we'll need 2,500 beds. We've probably delivered about 500 of those since that report was done. But if we don't do that reform, we need 7,000 beds. And I think that's well known that we are short of capacity.
Fair enough, Jim. But wouldn't it help, given that we have to increase the capacity, wouldn't it be helpful if, for example, you didn't have to negotiate with private hospitals, but you just had that capacity? Wouldn't that be better? Or if we knew what was on their books, which we don't really know in terms of the cost of beds, wouldn't that be better, notwithstanding the need to ramp up the capacity? And can I just ask very quickly, in terms of ramping up that capacity, I think it was one of our witnesses earlier on, Alan Irving, suggested that we should be looking at local solutions to try and quickly ramp up capacity. Are we looking at that? I'll just give you one example. There's 2 buildings of 17,000 square metres at Merrion Gates called the C-Mark buildings, sitting right beside, empty for the last 5 years, sitting right beside Vincent's Hospital. When there's talk of setting up modular hospital beds, wouldn't we be better going in and immediately purchasing those blocks for increasing capacity on an emergency basis, just as an example?
So I do think it depends on the time frame you're looking at. We talked earlier about the purchase of a hospital, and if you have a year or two, then in that situation, we had days at the start of this arrangement, and the quickest and most easiest way to do that was by agreement with the private hospitals, which thankfully we got, and they came forward on that. The other options, whether they're purchase or nationalisation or so on, bring you into a much more convoluted policy development process and legal process. Mr. Woods has talked about the bespoke solutions that are available in different sites in the public system that we have been pursuing in parallel with this, and I won't commit to making an offer on a building on the Merrion Road, but each hospital is looking at their ability to surge and to introduce new capacity as part of this.
Thank you, Mr. Breslin. Deputy Matt Shanahan, have you 5 minutes?
Thank you, Chair. Direct just a couple of comments there to Mr. Breslin, if you please. Just in respect of your comments about 4 fire tenders being sent out, and aren't we glad that we did? I would agree with that, but I would also say that pretty soon we discovered that 2 fire tenders had the fire under control, and we could have sent those other tenders potentially off to treat fires elsewhere. In other words, the undercapacity was looked at, was recognised, nothing was done about it. I would say to you, just in terms of this morning's briefing, you said earlier on, I think in your statement, that a partnership arrangement was entered into with respect to the private hospitals and with the consultants in there. I note that the IHCA wrote to the department at the end of April outlining the capacity issues and the fact that basically there was about between 20 and 30% capacity being used. I'm wondering what steps did you implement at that stage to try and recover some of the costs, because I think what's at odds here is public monies. This is what people are questioning, especially considering the time frame that we're now going into and the variable cost that we're going to see as a result of all of this. Also, Mr. Varley outlined in committee earlier that he learned in the media that a Type A contract was to be introduced on doctors, and he also learned that indemnity insurance might be removed. Basically, I'm not sure that that's a partnership arrangement I'd want to enter into, so you might just give response to that, please.
On the first question, what I would say, and I've said it earlier, is that we did move rapidly through different plans. We started off in a situation where a surge had to be planned for. When that didn't materialise, the heads of terms had already provided for further activity, non-COVID activity that could take place in those private hospitals. And the focus of everybody's effort was to promote that. But it was in a situation, and I think people keep forgetting this, between the 27th of March and the 5th of May, NPHET had said that routine healthcare services should be paused. So it was against that backdrop that we were working. In relation to utilisation and the IHCAs, we, and I won't speak for everybody in the room, but we, I think, collectively have spent many, many weeks of hours trying to engage with the IHCA to try and find a way through that would unlock the commitment of private consultants, about 50% of which signed up pretty readily, but quite a number had very significant concerns. And we clarified and clarified and clarified. We weren't in a position to give them what they were looking for, but we certainly gave them clarification over a very protracted period in the hopes that as many of them would come on board as could. It was a voluntary arrangement, and certainly more and more came on as the arrangement continued.
I'm not sure, Mr. President, whether there's an ideological block here, but I'm just wondering, on May the 8th, a letter from the State's Claims Agency, signed by a gentleman with the initial CB, instructed pathology labs not to process specimens unless the sending consultant had signed a Type A contract. How does that fit into public health care and cover, can I ask?
Well, two things. That was in a situation where the public purse was paying for the full running cost of the facilities, and so the person who signed it, issued the letter on that basis. But within 24 hours that was clarified and arrangements were put in place to facilitate that.
Well, with respect then to the payments, so in the period of the 3 months, I think the premium income that would have been paid over to private health insurers is the order of about €700 million. I think the rebate that's come back is about €180 million. So that's €520 million of monies that could have been put into the private hospitals to take account of the efficiency that was there, other than the fact that we had consultants who were essentially blocked out. And I am all in favour of a single-tier health service, but I think the issue here is about efficiency and cost, and I think it has to be questioned how we put a contract in place for €115 million a month, and yet we were working off bed capacity of 20 or 30%, and in actual fact elective capacity that fell way short of that, particularly in the early months.
So I just would ask people to reflect on the fact that there was a public health restriction on the operation of our healthcare facilities. I don't say that that's the whole explanation, but I think it is an important contextual factor for why all of our hospitals weren't as busy as they are in normal times. People have associated that, the impact of that, with the arrangement with the private hospitals. There is no doubt that there were challenges in the arrangement. It involved 18 hospitals, it involved over 500 independent hospital consultants, and arrangements having to be made in each of those instances.
Thank you, Mr. President. And just one more thing. Could I ask, will you give a commitment now in this new contract that you will find a way or a mechanism to get all of these doctors back in so we can get maximum efficiency through both the public and the private space, please?
So we will work to a mandate the government has provided to us, which is that we seek to put a retainer in place around capacity to surge if those facilities are needed, and that we will also put arrangements in place for particular cohorts of patients to be treated, but that it won't require 100% of the facilities of the private hospitals, and that's the policy mandate that...
Thank you. I'm sorry, Deputy Shanahan, we're out of time, Deputy. I'm sorry, Deputy. Deputy, we're out of... Thank you. Deputy Michael Collins.
And again, welcome to our people that have come here today to give evidence here. 2 months ago, on April the 1st, the Health Service Executive took over all of our private hospitals in a bid to be prepared for the surge of COVID patients, as had happened in Italy and Spain and other countries across the world. While it was very important to put these contingency plans in place, thankfully it was not needed. However, as a result of the 2 months shutdown of normal services, the HSE is now trying to cope with the thousands of patients on waiting lists whose appointments were cancelled due to COVID. The deal between the HSE and the private hospitals will not end until the end of June, by which time the waiting list will have become longer. One Galway oncologist recently stated that he had 60 cancer patients on a waiting list and 3,000 active cancer patients on his room list. These, he said, were patients whom he had treated in the past and who may be having a relapse during the shutdown period. This 3-month delay has affected cancer patients, orthopaedic surgery and all routine elective inpatient, day case and outpatient procedures, which were halted on April the 1st to free up space for the feared spike in COVID patients. We're all well aware that delays in biopsies, early access and treatment is likely to have consequences for patients, and this could mean loss of life. It is a very serious issue for all cancer patients, be they public or private. All cervical screening has been paused in the past 2 months, and now we have a huge backlog of which will not be cleared for months and maybe years. And the question I'd like to ask the agency is why could the laboratories not have been tested these smear tests in tandem with the COVID testing, and thus minimising the risk to women's lives through early detection?
Thank Thank you, Deputy. So the laboratories in the laboratories and hospitals continue to operate and did perform tests. So were cancer tests required through, say, rapid access clinics, they were happening. But I think maybe the point you were after is for screening, which can give rise to tests. The screening had been paused, and so that was a real effect. And as I've said earlier, it's a priority to get that back and running in a safe way.
Yeah, as I understand, if the private hospitals are lying idle, while patients' appointments had been put on hold, in addition to that, patients were advised to stay at home, which meant that cancer patients missed treatments and an oncologist's waiting list grew longer in this time. Several of my own constituents told me that their appointments had been cancelled, with no idea of when these appointments are likely to be rescheduled. From what now that the number of deaths from COVID have thankfully fallen significantly and new COVID cases being recorded has fallen dramatically, the question is, do the private hospitals have to wait till the end of June before they start seeing patients again?
Thank you, Deputy. No, they don't then, and the private hospitals are seeing patients now, as we've discussed. I think you're referring, though, specifically to delays in access to outpatients. And I would remind you that half of all pure private consultants, of which there are an estimated just under 600, are not part of the arrangement, and they presumably are seeing their patients. The other consultants who have signed into this arrangement can see their patients in the context of the heads of terms that is in place. So there isn't a reason why there is an incapacity to see patients. There is a disruptive effect of COVID, which you have referred to, and that has had an impact both on patients' own choices and on service provision in the last period of time. And I think, as you rightly say, our experience in the public system, where there are 3,200 consultants, has been that there's been a significant fall off in both outpatient attendances and emergency department attendances, which are now thankfully returning to more normal numbers. But the key point is that in advance of this arrangement coming into place, there was a significant fall off in both public and private system as the impact of COVID came more into the public consciousness and impacted hospitals. So our priority, of course, is to use the remaining period of this arrangement and the wider public system, which has 11,000 inpatient beds within it, to provide the service that needs to be provided. And there's a major challenge for us, not just in cancer care, but across all services, to catch up with what have been growing demands for care, a pent-up demand for access to outpatient and inpatient care.
Yeah, and that leads me to my next question. Although the intention is to return to a full healthcare system as quickly as possible, I expect it is fair to say that we had extensive waiting lists in all our hospitals, both public and private, before the COVID crisis, after it affected us. Considering all the extra precautions which will inevitably have to be taken to ensure social distancing and safety measures to ensure patients and staff safety, I would like to know what is the plan that the HSE is in proposing to deal with the enormous waiting list for all types of necessary procedures while ensuring the safety of all involved.
Thank you, Deputy. So from our point of view, obviously to return to a level of service provision which probably will not be the pre-COVID level but will be greater than we've seen in the last couple of months will be very important. I think the future of this arrangement with the Private Hospital Association will also be important in terms of work being done. But I would also point out, Deputy, that the workflow through the emergency department, which is the biggest piece of the inpatient work in the HSE, and what happens that as we approach, will be of critical concern. And in an environment where we have capacity constraint, and as you've indicated, additional capacity constraint around safe practice in a time of COVID, that is going to be a big challenge. So the negotiations with the PHA in accordance with the government decision will be an important piece of that. There are other elements which we're also, and I've referred to earlier, around intermediate care that we're also looking at.
Deputy Brophy, please, five minutes, is it?
Chair. Just first of all, obviously, to start by thanking you for all your work to date and for all the staff in our health service and the HSE for everything they have done. I sometimes think when I sit here, I live in a parallel world where some of the questions you're asked seem to me to be the classic of Monday morning quarterbacking. I cannot imagine what the situation in this committee would be today if you hadn't secured the private hospitals, if you hadn't secured the capacity, and if we had needed it. Because it was, I think, and in fully supporting the deal which was done and acknowledging it, I think it was the right thing to do at the right time. And I think tremendous credit is due to yourselves in representing the state on that side of the argument. I also think the private hospitals weighed in quickly enough as well to put that deal in place. It's very easy now for some deputies, they seem to sit back and discard the level of achievement that the public through their actions did in flattening that curve and preventing the type of situations which we were rapidly heading towards, which were happening in Madrid and were happening in Milan. And I think it does us a disservice as a committee not to acknowledge the type of work. I want to go back to one or two things, because I think your fire brigades were well needed, well wanted. I wouldn't send any of them away early. I think you never take that risk. But can I ask you, you were asked by one deputy who didn't really give you a chance, particularly Mr. Breslin, to reply on, the deal was called a bad deal. You said it is a good deal. Why is it a good deal?
Primarily for the reason you've just said, that we would have had this. It was contingent on us being overwhelmed, and if we were overwhelmed, we would have had that. We will never be able to value that. The actual valuation of that and the cost-benefit analysis, and I've done them in my time, I don't know how you put a figure on that. That was the primary purpose of the deal. We then moved to Plan B when that didn't, and it wasn't that didn't emerge on the 1st of April. That didn't emerge over the course of April. We worked based on what had already been written into the heads of terms, that we could prioritise other essential care and other non-COVID care, and the HSE put arrangements in place to try and boost that. And getting that activity through was not easy, because it was in a situation of public health restrictions. Nor was it easy because we had moved into a completely new operational environment in the private hospitals than anything the HSE was used to. But we have seen a steady increase in the utilisation of those facilities. And
thank you for that. I mean, that brings me to a point I want to make. I'm so conscious of time. Obviously, people seem to have forgotten again that there was a pandemic raging. We were told we couldn't use our hospitals by NEFIT, who said, you can't be blamed for adhering to public health advice. But also, I think we need to be conscious of the fact that members of the public, including my own personal family and people I know well, and it's not good medical choice, but we're choosing to avoid, if they could, going to hospitals. You could have had all the capacity in the world there, and I think we forget so quickly that at that stage a few weeks ago, people would not have accessed that medical facility because people were genuinely terrified. I mean, and terrified is the right word for it. I thankfully, gratefully, because of what's happening now in our country, there is a nebble of normality returning, and we are seeing that capacity. I want to very quickly ask you one other thing. In relation to the cost, I agree with you, to do a deal that fast and to try and do a cost-benefit analysis could not be achieved. The open costs that you have with the private hospitals, it reflects the capacity level they're being used at. Is that correct? So, in effect, we are getting a good value for money deal. We can see what the costs are. We're paying for what we use. We're not actually paying more because they're at 50% or 30% or 20%. We're paying exactly what is in relation to that. And indeed, if you did ramp up capacity, you'd see that surge go up. Is that, just to clearly understand that we are actually paying for what we use?
Yes, we're paying actual costs. That's not me saying that you couldn't have pushed more activity through and it would have been worthwhile. We were all looking to do that. But what we're actually paying is the actual costs incurred. And if less cost is incurred due to less activity, then we pay less money across.
Can I ask you one final other question on it? In relation to the New Deal, I'm interested in very quickly knowing what your estimate is on the fact that if you have the private hospitals working at a reasonable level of capacity, they're 75% normal capacity and whatever, from the point of view where you would declare an emergency due to a surge, what does the department, the HSE, etc., what does the state side of it think in terms of how quickly could you convert back the hospitals, the private hospitals, to deal with the surge? And one very small other little question, I'm way over, I'll leave it at that.
The quick answer to that, I think, is it's days. We'll need to model it, but it will be days. It'll be days because how quickly the exponential growth can take off on you, and secondly, you would need to decant the private hospitals, so you wouldn't want patients in them. You'd need to run that down over a number of days. But I think it is days rather than weeks.
Thank you. Deputy Foley, are you next for 5 minutes?
Again, just to welcome the witnesses, and am I on here?
It is, in fact, if you sit
to welcome the witnesses and thank them for coming, and to, like previous speakers, acknowledge the superb work of our healthcare staff and the gratitude that we owe to them. Without doubt, it was the right decision at the right time to take over the private hospitals, and I think we would be we would have to be honest and fair in saying that. However, just 3 questions really. As the time progressed, it was clear that the full capacity of private hospitals was not required. So at this point now, the decision has been taken to terminate that contract. But there is an acknowledgement that a new contract will be required should. Unfortunately, we would hope not, another surge occur. Could I ask, just in relation to that contract, who will be party to those negotiations? This morning we would have heard distinct disappointment and indeed acknowledgement that it would have made the situation less fraught if we say the consultants were also around the table with the private hospitals in relation to that. So if I could ask, will the consultants be party to those new negotiations, and what is the time frame you envisage? Now, I bear in mind that it was last Friday that it was terminated, but what time frame is there going forward for the completion of those negotiations?
On the state side, the HSE will be the contracting authority, the department will participate, and the Department of Public Expenditure and Reform will participate in the negotiations. The negotiations will primarily be with the private hospitals. That's the arrangement that the National Treatment Purchase Fund has. They pay for the services incurred by the private hospitals. I take the point, although this was a novel one where we were trying to convert private hospital consultants into public employees, that there was a need for engagement with the private hospital consultants. We will engage with the private hospital consultants, but the contract will be with the private hospitals in this case, I would envisage. How long it will take, there was already contact made with the Private Hospital Association on Friday. We've agreed to come back to them later this week with the type of arrangement or proposal that we might seek to bring forward, and we would hope to do quick negotiations over the course of the next couple of weeks to try and conclude this in good time for the rundown into the end of June.
Okay, thank you, Mr. President. I would appreciate the time was not on your side in terms of negotiation previously, but to my mind, it would make the whole situation going forward less fractious if the consultants were very much part of the discussions from a very early stage. Could I ask a specific question in relation to a point that was previously raised in relation to the fact that no pathology specimens could be processed unless the sending consultant had actually signed a Type A contract. Now, I appreciate what you said, that was rescinded within 24 hours, but the motivation for that, you've also suggested, was a financial one. I suppose, really, 2 things in relation to that. Could you confirm to me that absolutely no patient was negatively impacted because of that original decision? Could you confirm that that will not arise going forward in this new contract, financial or otherwise, whatever the implications might be? And thirdly, are you in a position to tell us who actually directed that, who made that decision in the first place?
So I wasn't involved in the actual events that gave rise to that. So I am, if I get it wrong, maybe somebody here could clarify it for me. I don't see it in the future in the sense that this arrangement going forward is unlikely to entail 100% control of those facilities, so the private hospitals will still be able to do work outside of the arrangement with the HSE, so I don't envisage it going forward. Given that it was within 24 hours and it was a lab, for lab requests, I don't envisage that it had any significant impact other than potentially 24 hours of disruption, but not interfering with a result. I can't see how that could have happened. And in relation to how it came about, I think there were lots of clarifications being sought in what was a complicated situation around the extent of clinical indemnity, which is a state insurance scheme, a state indemnity scheme, the extent to which that covered certain things and didn't cover other things. And the communication that issued was seeking to clarify that, but left one piece of it unresolved, and that, when that was seen, that was addressed within 24 hours.
one final question, just in relation to the fact that you've both said that private hospitals are at running at a much higher capacity now, even in terms of operating theatres and that. Would that be because in tandem the public hospital, we say theatres, are also running at full capacity? Are they both running at almost full capacity at this stage, or is it the fact that some capacity in the public hospital has actually been stood down? Yeah, has been stood down.
The public system is returning to theatre activity. It's not at full capacity yet, and I would point out that the additional ICU beds that have been stood up in the public system are heavily dependent on theatre nursing to sustain them, and indeed other nursing staff, but theatre particularly. So part of the return to normal theatre is also being comfortable that the ICU capacity that has been stood up on a temporary basis is safe to release.
Okay. Deputy O'Reilly, please.
And thanks to our witnesses and indeed thanks to everyone involved for your ongoing work. We do fully appreciate how difficult this is for everybody involved, and we know the effort that has gone in to date and continues. So I think you can possibly take that as a given, but it's still important to say it nonetheless. My first question is one in relation to the value for money element that's clearly absent from this entire exercise. So there was no value for money analysis done, no cost benefit analysis done from what I can gather. What kind of economic analysis was done at all? There has to have been some. I mean, you're talking about spending a large amount of money, Mr. Breslin. You're talking about a department that has frequently in the past had to answer in public over what is perceived by some as being a waste of public funds. So clearly some economic analysis was done about the level of money that was being spent. To what extent was any economic analysis done? Who conducted it? And can you share the findings of that with us?
So there were different economic analysis done. Both the HSE and ourselves would have done financial analysis. We took advice from New Era, which is part of the National Treasury Management Agency. We were dealing with the private sector and the commercial sector, so we went specifically to New Era to see what the approach there would be. And in each case, we looked at different options in terms of reimbursement mechanisms. For example, we could have used the National Treatment Purchase Fund schedule of fees that are operated. We chose a cost recovery model. Had we used the National Treatment Purchase Fund, it would have given a very significant level of uncertainty because we weren't able to specify in advance the schedule of services that we would need over the course of April. It was just too unpredictable. So the model that we went with, based on all of that option appraisal, was a cost recovery model, and the HSE has independent advisors in operating that model to validate the costs, verify the costs before final payments are made.
Before the final payments, but after the money presumably has been spent. So just ask in relation to that, can you share that information with us, Mr. Breslin? Sorry,
we were talking over each other. I just finished. The money is advanced, and then there's a reckon up done based on accounts, and then a balancing payment is due. And I didn't hear your question then. So just on that, we won't know the cost of this then until long after this deal is concluded, am I right? We won't know the final cost, but actually the validated costs have come in below the estimates provided by the private hospitals. So to that extent, it's come in lower than the initial estimates. But we still don't know the final cost, so it could actually be a figure that's higher in the end. That's likely, yeah. Well, we don't know that. So can I just, in terms of the information that you have in relation to your economic analysis, can that be shared with us? We can provide the analysis to you. If it's, I don't think there's anything commercial in it, but we can provide it to you. Okay, so I heard you earlier referring to taking out 4 fire tenders and making sure that you had those available to you. Of course, you know, if you wanted a complete picture of that, you could say the conditions were created in advance for the fire to get out of control. So that was why, obviously, all of that additional capacity was needed, and we had that discussion with the representatives of doctors and consultants this morning. The 24th of March, we saw an announcement made by the Minister for Health that the capacity had been secured in the private hospital sector. But the actual deal wasn't signed for another week, so it was the 31st of March, 1st of April when it was signed. So in that week,
Who was involved in those negotiations? Was it just officials from Health and the HSE, or were there officials from the Office of Government Procurement there as well?
It was the HSE and the Department of Health throughout that weekend, and I think it was concluded on the 30th of March.
Okay, so there were no officials from the OGP or from the Department of Finance at that stage?
No, we had a mandate from government and we had to get the approval of both the Minister for Health and the Minister for Public Expenditure and Reform to the final agreement. Okay,
and was there a maximum price set at that stage? Given that the announcement was made, I mean, I know that reference was made earlier to you know, whether or not this was good value for money, and I think that's what people want to know. But certainly, making the announcement, but the deal not actually being concluded, you didn't put yourselves in a great position to do a good value for money deal, notwithstanding the fact that I and others welcomed the fact that the additional capacity was there. I mean, we all have a view in relation to why that additional capacity was so badly and so desperately needed, because we were watching what was happening in Italy. We could see very easily that our hospitals could, because of the conditions created, could very easily become overwhelmed. But in the intervening time, in that week, do you feel that you were hamstrung a little bit in the negotiations by the fact that the announcement was made but the deal wasn't done?
I don't know. I think the private hospitals knew what we were seeking to achieve, and that there was no way we could have done this in secret to say that we want immediate access to all of the facilities of the private hospitals in the state, and for them not to know that that was something that we really wanted.
No, I'm not suggesting that it could have been done in secret. What I am suggesting is going out to make an announcement before the actual deal was done, I think would have hindered you in terms of getting good value for money. But I think it's becoming very apparent, Mr President, that value for money wasn't an issue. And indeed, we won't know the final cost of this, and I think that's going to be fairly worrying for a lot of people. Just with regard to what I refer
that if there are statements made that speak to the bona fides of the people here, that we would actually get an opportunity to answer the question that you put again to me, that we had no interest or didn't put a priority behind.
I said it seems to me. That's how it seems to me.
So I reject that. I reject that plainly. I think we were about using the resources of the state for the most valuable thing that we could possibly do, which was to prevent people needing to access our healthcare services and not having hospitals available to them, and I stand over the decisions that were made.
Okay, so when it became apparent that a lot of money was going to be paid for this capacity that wouldn't be required, which is a testament to the work not just done by the general public, but also the fantastic work done by our healthcare workers. So when it became apparent that we weren't going to be using that capacity, that capacity would be available to us, that we were paying for that capacity, and cognizant, as I'm sure you are every day of the week, of the hundreds of thousands of people who are on waiting lists, was any plan B put in place? So I'm specifically even referring to that period in between when the announcement was made and when the deal was finally signed. In that week, was any consideration given to the fact that we may not use all of the capacity, so that a plan B could be there to ensure that that was utilised? Because we spoke this morning to representatives from doctors and consultants, and they were very clear that their belief that there was no plan B, that the plan was only to secure the capacity, but not necessarily to make full use of that. So was any thought given to a plan B in terms of if we don't use the capacity?
Yes, so the heads of terms have been laid before the Oireachtas, and they outline that there are different usage to be made of the facilities. So even before the agreement was reached, part of that was that there was a plan B, that if it wasn't needed for Covid-19, those facilities would be used for other purposes. And that was the priority, in parallel with having it on standby for Covid, that we would also use it for other purposes.
Yeah, but that's not, with respect, Mr President, that's not a plan. I mean, that's a statement that we'd like to use the capacity, but I mean, a plan would detail what you were going to use it for, and I didn't see that in the heads.
Deputy, I think there's a problem that when I'm finishing the question, then I'm hearing you, and I'm not actually able. It's because we're not.
I'm very conscious of the time, so go.
I'm not able. It's written into the agreement, and the HSE could speak to the kind of operationalisation of that, the different cohorts that were identified, both essential care and more routine care. But within the context that NEFIT had issued its advice on the 27th of March that routine treatment was to be paused.
No, and I respect that, and I'm aware of that. However, that advice didn't remain in place for the full duration of this. It's not in place now. So I'm just wondering what preparatory work was done to ensure that the best use could be made of that capacity for which the taxpayer is paying very dearly. And I will say again, this is my opinion, but it strikes me that there wasn't. The plan was only to get the capacity, but not to make the maximum use of it. And I would have thought, given, as I'm sure you and Mr Woods and others are very conscious of the fact that there are hundreds of thousands of people on waiting lists, that some thought would have been given to a plan with dates and procedures, etc. in it. And it strikes me that that wasn't done. And we will exit this and we will enter into the post-COVID healthcare world with the same, if not worse, in terms of our waiting lists, and with the capacity constrained by virtue of the fact that that the physical distancing will apply. And so it's going to make it even less likely that those procedures will be done, and those lists are going to get even longer. So it does strike me as a missed opportunity.
Maybe I'll take that. In terms of your observations on waiting lists generally, I think you're correct. We've seen significant growth in COVID. In terms of the heads of terms, as has been referenced already, there was provision in that which has been exercised to undertake work that is non-COVID related, and there are detailed interactions with each of the private hospitals around that, and NTPF, as I'd referenced earlier, have also played a role in terms of identifying patients who are currently on waiting lists who can be treated. So the challenge for us, as you've rightly identified, is to do as much as we can between now and the end of June and negotiate an arrangement going forward with appropriate care.
Thank you. Thank you, Mr Woods, and thank you, Mr Breslin. Deputy Burke, you have 5 minutes.
Thank each of the people here today for their presentations and for the work that they've done over what has been a really very difficult 3.5–4 months. The impression has been given here today by some people that today you could tell the private hospitals, we want all your beds, and tomorrow we could tell them that we don't need them. And I think it's wrong that that kind of an impression has been given out, because I think, and maybe Mr President, you might clarify this. My understanding is that the agreement was made for 3 months, but the plan B was planning for, if this epidemic lasted longer, then the agreement could be extended for a further period of time. Am I correct in that?
Months, and the HSE had an option to extend it by a further 2 that it could exercise unilaterally, so that would have been 5 months, and then thereafter it would be extended voluntarily. So we have an agreement now that has it's at the minimum. Government decision is that we will end it at the end of the 3-month period.
But as part of that agreement as well, my understanding is that if you wanted to end in the 3-month time period, you have to give a month's notice, which I understand has now been given. I'm correct in that?
Yes, we gave the minimum, we gave the notice required, which will see it finished at the end of June, and that's what we could do under the contract.
So, in other words, it is incorrect to give the impression that, which some people seem to be trying to do, that this thing was just dreamed up overnight. There was actually quite a careful plan put in place.
As I say, there were actually a number of successive elements built into the plan itself, both in respect to the termination provisions, which were in the favour of the HSE. It could decide to extend or it could terminate, and so having that available in this situation to the HSE unilaterally was a good thing to have, and we've exercised it. And the second thing was the type of services to be provided was also at the discretion. It was set out in the common purpose of the agreement, but the HSE itself could make the referrals over to the private hospitals.
Could I just move on to the issue now of using the facilities for the next 4 weeks? We had the example down in Cork where, going back over 12 months ago, we had a particular problem in relation to access to gynae services. We had over 4,500 on a waiting list. A lot of these were daycare procedures. I'm just wondering, have we identified any list at this stage in relation to particular areas where we can use the private hospital facilities now over the next 4 weeks and get the maximum use of it? Is there a plan in place for the next 4 weeks in dealing with that?
So I'll take that, Deputy. So in terms of, yes, there is. We're looking to grow the occupancy as best we can to do that. I should say that at the moment we are doing, as I said earlier, cancer work in hospitals. We've done cardiovascular work. gastroenterology. There has been transplant work undertaken in one hospital. So there is a plan to do significant work. And with specific reference to gynae lists in Cork, there is a strong focus on looking at a lot of work, as you know, I think good work was done in the last 12 months on addressing that list, and there's a focus on that in this next 3 to 4 week period.
Okay. And just could I go back to the other issue in relation to elective hospitals, and we've identified clearly where there's a need to build 3 elective hospitals immediately, and that's been identified for some time. In Cork we have, there's a lot of land owned by HSE in Sarsfields Court. I'm just wondering, it's a site that could be immediately fast-tracked. Is there any plan at this stage to look again at fast-tracking that now that we are going to have difficulties in trying to keep the same capacity for dealing with procedures in our existing hospitals? Therefore, we now need to urgently look at what we can do in a very fast time period.
Yeah, so there's already work underway, deputies, I think you're aware, looking at potential sites in Cork, and Sarsfields, as you say, is one site in Glanmire owned by the HSE, which could form part of that consideration. There are others, but there is a process underway with the view to...
Have we timelines now, and can we bring forward those timelines?
There are timelines, don't have them with me, but there is a process underway already, specifically in Cork.
But what I'm saying now, in view of what has now occurred, and remember the population of Cork has increased by over 130,000 people over the last number of years. It's gone from kind of 410,000 to 542,000 and is growing. Can we now bring forward those timelines in view of what has occurred now, and in view of the fact, that we had to take over 2 private hospitals, the Bon Secours Hospital and the Mater Private? We had to take over those in order to deal with this coronavirus.
Yes, absolutely. I would just emphasise, though, that before COVID, there was already a clear programme in Cork, and that should continue and should conclude as quickly as possible.
And can we get kind of an idea of timelines?
If I can return to the committee with that, I will do.
Okay.
Thank you.
And just finally, can I just ask in relation to, because of the number of, I suppose, very difficult times in relation to some of our nursing homes, as regards moving people out of hospitals now, do we have a difficulty with that, and what kind of numbers of beds are currently occupied by people who really should be in step-down facilities? And how fast can we deal with that issue in order to create the capacity for procedures that patients now require?
So delayed transfers of care are at the moment around 400 in the acute system. That has gone up from a low of about just over 200 if we go back a few weeks. So that is an issue. It is an issue we're working on. It's not all nursing home related. Some of that will be for home care or other specialist care, but that is a factor in the system at the moment. And there is work underway with the view to ensuring we move patients to appropriate locations of care as quickly as possible.
And can we kind of get deadlines on that? I mean, in the sense of bringing it back down to, down to where it was?
Well, that's an ongoing piece of work, because each week the system will produce a further 130 or so people who need to be discharged to a care environment or a home environment with support. But there is a project underway with regard to managing delayed transfers of care. And in terms of your information request, yes.
Thank you. We've gone way over, but we did have an extra time, but now I see we have another speaker, so Deputy McGuinness, please.
I first want to ask Mr. President, or point out to you that the last time that you appeared before the committee, a number of questions were asked, and a commitment was given that we would receive a reply in writing. And that hasn't happened, to my understanding, to date. Now, some of the very same questions were asked again today. And I want to know, will you give us a commitment that these questions, from the last day at least, will be answered?
The procedure is, Deputy, that the Secretariat writes to me as Secretary General, and I think I got the letter on a Thursday with 10 days to come back, which would have been the following Friday.
Just that it would have saved a lot of time today had we had got those questions answered.
Could I just also say then, Deputy...
Earlier on you mentioned the fact of, or you were asked a question...
I was going to reply to your...
Claims agency and the fact that the letter had gone out and had informed those concerned that if the consultant had not signed the A contract, that the tests would not be processed. And okay, that was fixed up, you say, in 48 hours, but it does bring about a situation where there's a mistrust growing between the consultants on one hand and the department on the other. And that was reflected again in the context of the contract itself, where some consultants write to us and tell us that contract B would have cost far less and done the same job as contract A. And I can't ignore these comments from consultants, and I'm not pointing a finger at you or the HSE. I'm simply saying that there is a staggering contradiction in terms of the witnesses as they present to us and what they understand what has happened. So in terms of the consultants' representative this morning, they informed us that they had written to the HSE or the Department of Health in relation to the contract and how matters were progressing, and they had received no written reply. They told us that there were 600 consulting rooms in place and that the officials ignored all of this. Now again, I'm not saying he's right and you're wrong. I'm simply saying that that is what was said. To Mr. Woods, I would say that again, a witness this morning highlighted the serious difficulties in relation to telemedicine and dealing with those affected by mental health issues. And in a separate letter from a consultant, they talk about the serious mental health issues and the well-being of patients now emerging from COVID-19 and the need for a direct one-to-one consultation, and that again telemedicine will not work, is what they're telling us. And one other witness this morning told us that the system of technology being used is abysmal. In fact, he said if we went back to the, I don't know what he said, the 1800s or not, that we'd probably have the same thing in place there at that point in time, which was certainly recording matters by way of manually entering the information. So that's a contradiction of what you said earlier on. I suppose a number of other contradictions there too. And I'm asking why such a difference has emerged. Like if you were close together, moving towards taking in charge of the private hospitals, and if you understood what was going on, there would have been a greater and a more significant cross-use in terms of public and private. And the last thing I would say to you is we were told this morning that 1 million patients have been affected by the cancellation of their appointments and their procedures.
I think all of us had extensive engagement with the IHCA throughout this period. I remember walking up and down my kitchen on a Sunday morning talking extensively to the General Secretary of the IHCA, and throughout weekends and late at night, a range of different officials were dealing with the IHCA, and we had protracted engagement. We were giving clarifications to the IHCA. That doesn't mean that we were agreeing with the IHCA, but there was no lack of engagement from us trying to get to solutions. It's important to recognise that we were working within the policy parameters that was set by government. One of those parameters was that there would be no private practice, there would be public only, there would be no private fee arrangements over the period of this. And so when the IHCA were looking for a Type B contract, they would have understood, but it's maybe not commonly known, that that would have entitled them to get private fees for treating patients. And that was contrary to the mandate that we had been given, and it was contrary to the heads of terms that had been concluded with the Private Hospital Association.
Well, would Mr. Woods like to comment on the issue of the...
Yes, you raised the...
mental health.
Yeah.
That is a concern.
So in terms of use of telemedicine, firstly, we had over 80,000 consultations using telemedicine in April, and I would acknowledge that was a significant mechanism to provide service to people who may not otherwise have received such service. I would also acknowledge that it would be broadly agreed that a first consultation would not typically take place using telemedicine, in other words electronically, but it would be quite routine in other jurisdictions that further consults can and do so, and there are excellent systems for that, and the HSE has those systems and they are in use. I think there was a point you made about 1 million patients affected.
Sorry, Mr. Woods, would you not accept what the consultant said to us this morning, that that is simply not the case, and that the technology in place presently is abysmal? And I'm quoting from the consultant.
Yes, and as you say, you find yourself presented with diversion of view. Because we're close together doesn't mean we agree, and we were very close together for quite a while. So from my point of view, I think, in fairness to the reference to technology that you were talking about, it's about recording patients as they attend, and there is a system gone in through the NTPF to private hospitals to support that, because the private hospitals themselves have a variety of systems, so we have to depend on what is there given the short timescales. I think, Deputy, there's one other point I should touch on. To suggest 1 million patients are impacted seems to me to be excessive. There is an impact in outpatients in the public system where there are 3,200 consultants working. We can see that there's a loss of appointments of about 150,000 in the month of April. So from our point of view, that's very significant, and we have to catch up on that. But it sounds to me, barring seeing more detailed information, and I accept you're reflecting what was represented to you, it seems to me that that's an excessive number.
Thank you. Deputy McNamara, you can see that.
One very discreet question. Obviously, cancer screenings were stopped right across the country and still are suspended. A number of private doctors who hadn't signed the Type A contract continue to carry out screenings in their rooms. They were told on a Friday afternoon that they were no longer, or that they wouldn't be indemnified by the State Claims Agency in respect of those. So in effect, they were prevented from carrying out any colposcopies or other screenings. Who made that decision?
That I dealt with earlier. I wasn't involved in the individual instance, but within 24 hours there was a clarification issued. The State Claims Agency was seeking to clarify the extent to which clinical indemnity was covered, covering the various activities in relation to this undertaking, and seeking to put clarity in respect of that. They had dealt with that issue, but very quickly they rescinded that and clarified that it would be covered.
It was just a lack of clarity rather than a decision.
It was an unfortunate issue, but it was rectified.
Thank you very much, Deputy McGuinness. Thank you indeed.
Much better than the usual one.
Could I just take just the shortest opportunity just to thank everybody and to thank the witnesses, not just for attendance and the preparation in attending today, but for the work that you've done over this period. I think it's been truly extraordinary, the exceptional work and the exceptional commitment to public service and the public service values that have been epitomised, how extraordinarily hard you've worked. And I just want, if I never got to say anything else about it, to thank you and to say that to you. Mr. Breslin, I know you and I worked together in the past a very long time ago, and I know very well that often what goes on behind in the departments and the level of work isn't always reflected in public, and I just want to say thank you. Could I just ask my own question, please, just in terms of the sequence of things, and forgive me just for going through it, but I think it's worth remembering because we have moved on, it seems, collectively very quickly from the terrible situation that we faced in the outset. You had a pandemic, a global pandemic, numbers rising, ICU admissions rising, evidence from other countries of overwhelming ICU capacity and the exceptionally difficult decisions that would have resulted in. And so it's on that basis that you made the decision to take over the private hospitals.
Yes, and the figures I gave earlier of a doubling in ICU capacity, given that we're not well endowed with ICU capacity, if that had continued at that rate, within a week to 10 days we would have exhausted our ICU capacity.
And so you said the decision was made very quickly in respect of private hospitals in a matter of days. Can you just give us a sense of really how quickly? I mean, what sort of period did you have to make?
So at government, I think the date that was used earlier was the 24th, and by the 30th that agreement was in place and patients were being admitted under the agreement into private hospitals.
And essentially at the same time, NEFIT suspended, if that's the correct term, access generally to the hospitals so as to try to continue to reduce community transmission and infection within hospitals.
Yeah, we were dealing with the same issue, which was that we were looking at a surge, but we were using different remedies. One was to try and flatten the curve and stop the surge, but we knew that the incubation period could mean that even if we were successful, there was a lag in that, and meanwhile we were trying to put the capacity in place for the surge. The fact that the first strategy worked meant we didn't need as much of the second, but they were both valuable strategies.
Thank you. As a representative, the queries that I was getting were, in the first instance, could I get access to treatment? And that got resolved pretty quickly. People were getting access for, injections to the eye. I don't want to get the term wrong, or continuing cancer treatment. And now the question is about getting access to ongoing diagnostic tests. And I'm sure you're aware of that pressure as well. And I think what people are really looking for is that sense of a plan over the coming months. And I know you'll be working on it. As it happens, I had the opportunity to we were talking about consultations, the opportunity to do virtual consultations, talking with Children's Health Ireland earlier about it, and where they're talking about parents doing videos and sending those in as consultations and doing a certain amount of diagnostic work, with then only having to attend for bloods or other things. So there's an opportunity, great opportunity for innovation at this time as well. And I just want to say thank you for coming and thank you for your work. And I'm to read out that we are now suspended until 4:30, when we'll be meeting the Department of Foreign Affairs, the Department of Health, the National Transport Authority on the issue of travel restrictions. And so the committee is now suspended. Thank you.